Hi, my name is Bianca Rhodes, and today I'm going to be talking about exploring the biological, epidemiological, and social determinants of rheumatoid arthritis. So, to begin, I want to talk about what rheumatoid arthritis is. We also refer to this disease as RA, and it is known to be a systemic autoimmune disease in which an individual's immune system mistakenly attacks the body's joint lining. More specifically that synovial joint. And this causes chronic inflammation, pain, swelling, and discomfort, and as well as numerous other things. And this chronic disease affects many people, including both sexes, and is most common between the ages of 30 and 65. But of course, this can range outside of those ages, and it increases with age. And we see that peak incidence age at 50 years old. And I wanted to provide a little image here so that we can see where specifically we see joints being affected and how this can cause that discomfort, swelling, and as well as deformity. So next I'm going to discuss the biological determinants of RA, and I'm going to talk about the genetics, the immune system function, and hormones. Okay, so to start, I want to talk about the genetics behind RA. We can see that individuals who have a family history are more likely to be diagnosed with rheumatoid arthritis, and we know the heritability of RA has been estimated to be around 60%, which is pretty high. And so we see an ACPA, which is an anti-citrullinated protein antibody. This is a key diagnostic marker of RA, so an individual being tested for RA will have a high ACPA, and the overall heritability of ACPA positive and ACPA negative of RA is similar at around 60 to 70%, so also pretty high. And then we see the HLA-DR4 and HLA-DR1, and these are specific types of HLA-DR molecules, which is a part of the human leukocyte antigen complex, and this plays a crucial role in the immune system by presenting peptides to T cells. So they are particularly associated with rheumatoid arthritis as well as other autoimmune diseases. But the DR4 is specifically linked to an increase in RA, and we see within the HLA, the heritability has been estimated to be 11 to 37%, so not as much as the others, but still pretty high. And we can see that hormones have been associated with RA, specifically because we see a higher prevalence of RA in women. And so this allows us to think that estrogen influences the disease. And we also see remission within pregnant women. So an individual who has RA, once they are pregnant, there's a switch in their immune system response, and this would decrease the production of pro-inflammatory cytokines. So many women who have RA during pregnancy will commonly experience remission. And next, we want to talk about the immune system function. So we know, as I said before, that the immune system mistakenly attacks the synovial joints, and this leads to inflammation, pain, and damage. So the surrounding tissue is attacked, and I provided a little image here that has a lot of immunology behind rheumatoid arthritis and the specific cells that go into attacking these joints. Next, I want to talk about the social determinants. So we're going to speak on the socioeconomic status, the access to healthcare, as well as working conditions. So within the socioeconomic status, we can see that the low SES is associated with increased RA and poorer disease outcomes. So this could be due to a variety of reasons, such as limited healthcare access, poorer nutrition, and increased exposure to environmental risks such as pollution. And we can also see that some working conditions could also cause negative effects to the condition, and this could be due to a job with repetitive joint stress and some exposures to toxins that can contribute to the risk of RA. And because exposure to toxins can trigger an abnormal immune response. And so we can also see that psychological stressors such as chronic stress, depression, or social isolation could be a determinant of RA, as well as access to healthcare, which could, if someone is limited to that, they could have delayed diagnosis, delayed treatment, and worsening of the disease progress. And so within these little graphs that I provided, we see the age-adjusted prevalence of rheumatoid arthritis by poverty income ratio level. And so that's what that PIR stands for. And this is going to be taken 2005 to 2006 and 2017 to 2018. And this shows the prevalence of men and women by poverty income ratio level, as I said. And so we can see that the poverty income ratio level compares a person's or family's income to the official poverty threshold. And so this can be calculated by dividing a family income by the corresponding poverty threshold. And so a ratio of 1 indicates the income is at poverty level, while the ratio less than 1 means the income is below the poverty level. And so this just gives us a little bit more of an idea of how that socioeconomic status can tie in to rheumatoid arthritis. And next I'm going to speak on the epidemiological determinants. This would be the prevalence, incidence, age and sex, as well as ethnicity. So we know that the global prevalence of rheumatoid arthritis is 0.24 to 1%, which may not seem like a lot, but it is a pretty big number. And so we see that, as I said before, that RA is more common in women, and we have a 3 to 1 ratio, as well as in the ages of 30 to 60, and prevalence increases with age. So, and we also know that 8 in 100,000 people between the ages of 18 and 34 get RA. So next we will talk about the ethnicity. So this can be seen to be increased in specific populations, and I found that really interesting. But a lot of the articles that discuss this just spoke on the genetic components that I talked about before, and how they were just more likely to have those, as well as if they were in a low-income area, then they had a higher chance of getting RA. So we saw Native Americans had a higher increase of RA cases, while East Asian populations were a lot lower. And I provided a map here from one of the research articles that I read, and this just shows us like the distribution of incident rates for both sexes throughout the world. So next I'm going to talk about the environmental and lifestyle factors, so smoking, nutrition, and pollution, and how this can contribute to RA. Oh, went too far. Okay, so I'm going to talk about pollution, and so certain chemicals can trigger health problems. More specifically, it could be linked to immune dysregulation, and we know that RA is an autoimmune disease, so that could be a part of that immune dysregulation. And we also know that smoking could be a major risk factor of RA, significantly increasing the likelihood and progression. So it is really recommended that an individual does not smoke, well, with any disease really. And so we can also see this in the nutrition of a person. So a diet poor in anti-inflammatory foods such as fruits, vegetables, and omega-3 fatty acids, and a diet high in saturated fats of processed sugars and red meats. This could potentially worsen inflammation and increase joint pain. And I provided a little image here just so that an individual can get a visual of that environmental risk factors for RA. So there's a variety of prevention strategies such as avoiding smoking, as I said, maintaining a healthy weight, exercise regularly, avoid environmental pollution, which can be hard sometimes, eating well, vitamin D supplements if necessary, as well as early screening if an individual has a high chance of getting RA due to family history. Okay, and treatment for RA includes the DMARDs. These are disease modifying anti-rheumatic drugs, and these can slow progression and consist of medications such as methotrexate, sulfasalazine, and uh, hydroxychloroquine. But these do contain a variety of side effects and risks. And we also see other treatments such as biological target therapies, which include TNF, IL-6, and JAK inhibitors. These are used in resistant cases, to help RA, and as well as supportive therapy such as physical therapy, and sometimes some cases are really bad and require surgery. And patient education is crucial as a treatment for RA. And of course, we would love more of a spread of health knowledge. This would be public awareness, patient awareness, and healthcare awareness that would allow for RA to have more knowledge around the world. And so controlling RA could be regularly monitoring, self-management, as well as a support system. And for future direction, we can use this epidemiological as well as risk factors associated with RA that could cause a dramatic change in the disease pattern with emerging treatment options and the ability to personalize healthcare and treatment approach for different disease attributes. And this could be done using the environment, genetic, and epigenetic conditions found within the individual. So, furthermore, the advancement in personalized medicine, stem cell and regenerative therapy, telemedicine, and public health initiative is the future to controlling and regulating RA. And that's it. Thank you so much. Have a great day.